So talking about calcification, the treatment modality will purely depend on the type of calcification. As you all know, there can be different types of calcification. The calcium, which is with the smooth surface, non-protruding into the lumen. Calcium can be nodular calcium, which is only in one area protruding deeply into the vessel lumen. What is the difference between superficial calcium and deep calcium? The management of calcific lesions, when it is deep and superficial, entirely differs. Let us have a look at them. There is other then there is thinner calcium and thicker calcium. That also matters when it comes to the treatment. The intravascular imaging in calcified lesions will predetermine the treatment schedule, what we have to take. The type, location, angle, thickness, all these things matter. Adequate lesion preparation and safety of the usage of the device will be dependent on the type of calcification. Post-intervention, again, stent expansion can be determined purely by intravascular imaging. In calcium, is there any scoring mechanism to determine whether we need to use any other device or plain balloon would be good enough? There is an intravascular IVUS scoring system which has been developed. Higher the score, more difficult it is to handle, and we need some additional devices. In OCT also, we have the similar scoring mechanism. Higher the score, we need some device to modify the calcium, is something which we have learned over the last so many years. There are situations we can have calcification, but we may not need anything more than a balloon. That could be a cutting balloon or a high pressure balloon. In this particular case, a cutting balloon is used in a calcific proximal LAD. You can see the result, and final result with the IVUS finding shows that it is a well deployed, well opened vessel. When superficial concentric calcium, the balloon response will depend on the type of calcification. When it is thin, just high pressure balloon or a angiosculpt or a cutting balloon should be enough. You can see the proximal LAD lesion and the post angiosculpt, you can see a reasonably satisfactory result. And you see, look at it on IVUS, you can see the cracks in the calcific layer of the inner layer. Thick superficial calcification will need something more than the plain balloon. It could be a rotational atherectomy. Today we have other options of IVL or ELCA. These devices are depending on what we need. This particular patient has got a very dense calcific lesion, concentric. You can see it again. The second loop, which shows that the extent is across the whole mid-right coronary artery, which was treated with the rotablator followed by balloon, and IVUS shows that it was the calcium was debrided, and final picture shows very reasonable and satisfactory result. And if you look at the IVUS, you can see the stent is well expanded and the calcium is cracked at multiple points, and this was responsible because of we used the rotablator to debride the calcium. This is another patient where got a very densely calcific bifurcation of the LED circumflex. And what we did is we used you can see the last frame, you can see we used a rotablator in that particular case. Dense calcified circumflex ostium and the LED ostium and the proximal segment of the LED. Then we rotablated the LED. By the time we rotablated the LED, the circ decided to close down. So we had to go in and open that vessel with a high pressure balloon, followed it up with IVL, and this is the OCT picture of that patient. You can see the dense calcification in that, which was followed by stenting of the circumflex also. And so the use of combination of multiple devices would be necessary in very difficult cases. In conclusion, coronary artery calcification remains the main determinant of optimal stent expansion. Thinner calcium plates break easily with balloon dilatation alone. In case of thick eccentric calcium, stent expansion occurs eccentrically along the non-calcified segment of the vessel. In case of thick concentric calcification, atherectomy results in focal calcium thinning and then fracture of the balloon with the balloon dilatation. In case of nodular calcification, step-up burr may be necessary or an orbital atherectomy or IVL may be needed in some cases. Intravascular imaging helps in deciding the need for atherectomy or intravascular IVL. So how do we decide? Moderate to severe calcification, you have two options. Whether IVUS or an OCT is possible. If it is no, then we have to go on to wiring it. You can use a rotablator if you can get a rotawire in. There are situations rotawire will not be able to position inside the vessel because of the tight lesion. We may have to use the ELCA laser first, followed by atherectomy or an IVL, and followed by optimal lesion preparation and stenting. If it is IVUS is possible, the second group you have seen on the left panel, then you can divide into two: nodular calcium straight away, orbital or IVL or rotational atherectomy can be helpful. If there is a plate of calcium and the calcium score is high, again follow the same routine. Any of these devices will help. So to summarize, the scenario of treating calcific lesion is become brighter. There are very, very few situations where we fail to dilate the vessel because we have so many devices available to us today, which combination may be necessary, but ultimately we are able to get an optimal result. Thank you very much.